Ve moderatörlüğü de yapacak doktorumuzun biraz özgeçmişinden bahsetmek istiyorum. Belki tanıyanlarınız vardır. 2005 yılında İstanbul Üniversitesi Diş Hekimliği Fakültesinden mezun oldu. Daha sonra İstanbul Üniversitesi Diş Hekimliği Fakültesi Ağız, Diş, Çene Hastalıkları ve Cerrahisi ana bilim dalında doktora eğitimine başladı. 2005-2010 yılları arasında fakülte bünyesinde akademik ve klinik çalışmalar yürüttü. 2011 Nisan ayından bu yana burada Antalya'da bulunan kliniğinde çalışmalarını sürdürüyor. 2012-2022 tarihleri arasında Antalya Diş Hekimleri Odası Yönetim Kurulu üyesi, genel sekreterlik ve başkan vekilliği görevlerini yürüttü. 19. dönem Türk Diş Hekimleri Birliği Merkez Yönetim Kurulu üyeliği görevini de yürütmekte. Alkışlarınızla Doktor Recep Uzgur'u davet etmek istiyorum. Doktor, sunumunuza başlamadan önce biraz sohbet etmek isterim.
Olur.
Nasılsınız?
Teşekkür ederim. Sizler nasılsınız?
Çok teşekkür ederim. Yapay zeka hepimizin mesleğini yavaş yavaş elimizden alıyor ya ve gelecekle ilgili endişeler hep bu yönde. Diş hekimleri için de benzer bir endişe var mı? Sizce?
Günümüzde yapay zeka hepimizin bildiği gibi hızla ilerliyor. Sizin bu sorunuz çok önemli. Ama yapay zekanın önümüzdeki 20 yılda şu anki bilimsel çalışmalar gösteriyor ki ilk yerine geçeceği meslekler daha çok tek düze ve tek aşamalı olan meslekler. Mesela kamyon şoförlüğü gibi ya da sunum yapmak gibi. Ama aşamalı meslekler, anestezinin yapıldığı, çürüğün temizlendiği, daha sonra ölçünün dijital olarak alındığı, 3-4 kişiyle en az yapılması gereken ve tıbbın ve anatominin en detayına kadar bilgi sahibi olması gereken mesleklerinin yerine geçmesi biraz daha zaman alacak. Muhtemelen alacak. Şimdilik bize yardım ediyor. Diyagnozda yani tanıda veya tedavilerimizi hızlandırıyor. Özellikle şu an çürük tespitinde çok kullanılmaya başlandı. Evet, hepimiz tehlikedeyiz. Bakalım.
Ama bu kadar ince işler yapan insanlar olarak bir 20 sene daha güvendeyiz diyorsunuz.
20 sene daha güvendeyiz. Hakikaten öyle. Ondan sonrasını kimse bilmiyor.
Bir haber gördüm, onu paylaşmak istiyorum sizinle. Bir gen ayrıştırılmışlar. Bugün gördüm haberi. Küçük bir diş parçası varsa ağzınızda, ona o geni aşılayarak tam bir diş haline gelmesini sağlamışlar. Ve 2024'te bu gerçek olabilirmiş. İnsanlar üzerinde de denemeye başlayacaklarmış diye duydum.
Bu çalışmalar...
Dükkanı kapatıp gidelim demiyorsunuz değil mi eğer öyle bir şey olursa?
25-30 yıldır bu çalışmalar devam ediyor. Belki sonlanmaya, yani sona doğru gelmiştir. Bilemiyorum ama sonuçta onu yine bir diş hekimi koyacak oraya. Yine bir diş hekimi operasyonu yapacak ve onu yine bir diş hekimi takip edecek. Daha sonra o yine çürüyecek. Yapay zeka mesleğimizi almamışsa eğer yine biz dolgu yapacağız. Biraz zor ama
zaman
olacaktır.
içinde işimiz kolaylaşacak ama aynı parayı kazanmaya devam edeceğiz diyorsunuz. Çok sevindim.
Muhtemelen.
İyi sunumlar diliyorum.
Çok
Buyurunuz.
teşekkür ederim. Arkadaşlar hoş geldiniz hepiniz. Kıymetli meslektaşlarım. Harika bir gala gecesinden sonra burada olmak hepimiz için zor. Yine aramızda görüyorum ki en iyi durumda olan Bay J. Benim özgeçmişimle ilgili küçük bir problem oldu. Şu an yazdığı gibi kendimi tanıtmak istiyorum kısaca. Ben Atatürk Üniversitesi mezunuyum. 2008 yılında daha sonra Ankara Üniversitesi'nde protetik diş tedavisinde doktoramı tamamladım. Farklı yerlerde çalıştım. Yaklaşık 6-7 yıldır da tam dijital iş akışıyla kendi kliniğimizde tedavilere devam etmekteyiz. İlk oturumun moderatörüyüm. İlk oturumu ben modere edeceğim. Başlayalım hazırsanız. 2024 Antalya'da düzenlenen Osstem Türkiye toplantısının bir parçası olmaktan her zamanki gibi gurur duyuyoruz. Türkiye'nin dört bir yanından yoğun programımıza rağmen ve dışarıdaki harika güneşli havaya rağmen katılım sağladınız. Hepinize içtenlikle teşekkür ediyorum. Günün ilk konuşmacısı Güney Kore'den Yongjin. Yongjin, Diş Hekimliği Fakültesinden başlayarak tutkulu bir yolculuğa çıktı. Ulsan Üniversitesi Tıp Fakültesi'nde ağız ve çene cerrahisi üzerine yüksek lisansını tamamladıktan sonra Seul Asan Tıp Merkezi'nde uzmanlık alanında deneyim kazandı. Biraz özgeçmişinden bahsetmek istiyorum doktorumuzun. Kore'de çene ve plastik ve rekonstrüktif cerrahi alanında diplomatik unvanlarına sahip olan Doktor Kim, aynı zamanda ITI üyesi ve Wuri Genel Hastanesi Ağız ve Çene Cerrahisi Bölümü Direktörü olarak görev yapıyor. Hastalarına CV'sinden de anlaşılacağı üzere en iyi tedaviyi ve bakımı sunmak için kendini adamış bir lider. Ve bugünkü sunumunun konusu dijital iş akışı ile tam çene implant rehabilitasyonu. Kıymetli meslektaşlarım, Kim Yongjin'i büyük bir alkış ile sahneye davet ediyoruz.
Very good morning, everyone. I'm Dr. Yongjin Kim from Korea. Very nice to meet you guys all again. So actually, I have visited this Antalya exactly 4 years ago, just before the COVID pandemic. So I'm very happy to be here again to share my surgical experience with you guys all. Today, I will be talking about my full arch implant rehabilitation protocol by utilizing digital workflow. Sorry. Yeah, after watching this video clip, you guys can understand what I wanted to say. So when placing implant, especially when placing multiple implant, the distance between implants should be secured in order to maintain the interproximal bone, in order to maintain the papilla. So, as we all know, malpositioned implant will cause several problems: aesthetic problem, mechanical problem, and maintenance problem. To solve these kind of problems, we should place implant in ideal position. So, how can you place implant well? Traditionally, we always imagine the size of restorative crown, and we should start the drilling at the center of that imaginary crown. So, to minimize these kinds of implant problem, we should place implant at the center of restorative crown. But if your patient doesn't have remaining teeth, what should you do? How can you find out the ideal position of the implant? Also, when performing full arch implant rehabilitation, we should imagine entire occlusal scheme. So also we should consider lip support, the amount of alveolar bone. Also, we also establish occlusal plan and vertical dimension. So what if your technique and your experience is insufficient to satisfy your patient aesthetic demand or your patient demand? In this situation, we can utilize digital technology. So I'm an oral and maxillofacial surgeon, so I was an analog dentist. Usually, I always open the flap widely to find out anatomical reference point, especially when performing full arch implant rehabilitation. But now I'm trying to be an Iron Man. To maximize my surgical skill, I require some suit to be an Iron Man. The digital technology can be my suit to be an Iron Man. So that was my previous surgery style. I always open the flap widely. In this way, I could find anatomical reference point. By checking the anatomical reference point, I could find out ideal drilling point. But in this way, I usually place implant with surgical template. So in this way, we can minimize invasiveness. We can place implant in ideal position. So why should we consider digital guided implant surgery, especially for full arch implant rehabilitation? These are my main reasons why I'm using digital guided implant surgery, especially for the full arch implant rehabilitation. First, we can get blueprint of entire treatment result. When considering the workflow of digital guided implant surgery, we should make prosthetic design first. Based on this prosthetic design, we will make an implant placement plan. So with this prosthetic design, we can discussed with our patient. Patient can expect entire treatment result after implant placement. And also, we can place implant without flap elevation. Some situation, we can elevate the flap, but minimal incision and selective flap elevation can be done. Also, we can place implant in ideal position to minimize aesthetic problem, mechanical problem, and maintenance problem. So this is quite an attractive point for dentists. Educate precision of implant placement provided. Free fabrication of prosthetic reconstruction and immediate loading may be possible. By utilizing digital technology and by placing implant with surgical template, we can prepare provisional restoration just before surgery. And then with this provisional restoration, we can perform immediate loading. So let's talk in detail with some cases. So these are my very brief workflow of full arch implant rehabilitation. For the first time, we should place implant, and then we should deliver provisional restoration, denture or fixed type. And then this provisional restoration should be converted to final restoration. So when placing implant, according to your preference, you can utilize guided surgery or freehand surgery. Also, we have two options for provisional restoration, removable type and fixed type. If you guys can follow the digital workflow from surgery, you can prepare the provisional restoration before surgery. And with this prefabricated provisional restoration, you can perform immediate loading simply. So let's talk about this case. This patient was a 63 years old male patient, referred to my clinic to place implant. Upper full arch implant placement, lower multiple implant placement. So this is a sinus floor. Because of prolonged edentulous status upper maxilla, upper posterior area, the residual bone height to the sinus floor was quite limited. So crestal approach sinus lifting should be considered. Pre-op condition is here. So when considering final prosthesis type, we should consider some factors. The amount of residual bone resorption, vertical dimension of edentulous site is a quite determining factor. And also, the amount of lip support should be considered. Even though you guys can augment the bone vertically or horizontally, if there is no lip support with fixed type prosthesis, at that situation, we should consider removable type prosthesis, which can support the lip. The lip support is quite important and determining factor when considering final prosthesis type. So let's see. When considering vertical dimension of edentulous side, the vertical dimension was less than 11 millimeter. In this situation, fixed type segmented prosthesis will be a best choice. This distance was less than 11. So I decided to place several implants, 9 implants in the maxilla to make a fixed type segmented prosthesis. So here, this is workflow of this patient. Implant placement was done with digital guided implant surgery with one guide system from Osstem. Upper jaw, crestal approach sinus lifting, and anterior augmentation GPR was done. So for the maxilla, complete denture was selected as a provisional restoration. In the mandible, I placed the several implant and immediate loading was done with prefabricated provisional restoration. When considering the opposite arch, in the lower jaw, we can perform immediate loading with high predictability and the success rate. So during planning, I could check the actual residual bone height from the sinus floor. So based on this, I could decide how to make a drilling and how to elevate the sinus membrane. So, but how can it perform crestal approach sinus lifting through surgical template? Previously, it was impossible. So because during drilling through the guide hole, drilling depth cannot be controlled. And also, this surgical drill, conventional surgical drill has very sharp apex. So at the moment of sinus floor penetration of this drill, sinus membrane can be torn easily, like this. So previously, we should perform crestal approach sinus lifting without surgical template or removing surgical template. But in this day, we can perform crestal approach sinus lifting through surgical template, especially when using one guide system. So we have some advantage when performing digital guided implant surgery, like this. We can get actual residual bone height exactly from the drilling side, minimum residual bone height and maximum residual bone height. Based on this information, we can decide drilling protocol. Initial drilling depth should be at least 1 millimeter shorter than minimum residual bone height. Maximum drilling depth should be same as maximum residual bone height to penetrate sinus floor completely. If you guys can use this one casket, we can perform crestal approach sinus lifting through one guide surgical template. This is a one cast drill. Unlike the one guide drill, one guide kit is Osstem's digital guided implant surgery kit. One guide drill has very sharp apex, but unlike one guide drill, one cast drill has a rounded design. So at the moment of sinus floor penetration with this one guide drill, conical bone lead will be formed between sinus membrane and the drill. So with this conical bone lead, sinus membrane population risk can be minimized. Also, by connecting the stopper to this one cast drill, we can control the drilling depth exactly. Also, to detach and elevate the sinus membrane sufficiently, we can use this hydraulic lifting system through the guide hole without removing the surgical template. Quite attractive, especially for full arch implant placement cases. In some situation, if you guys wanted to pack the bone, you can pack the bone through guide hole. So, in the maxilla, right after all remaining teeth extraction, one guide surgical template was fixated with 3 anchor pins. And then, drilling and anterior implant placement was done. Molar area, because of very limited residual bone height to the sinus floor, crestal approach sinus lifting with one casket was done. I connected the stopper to the drill, and I increased the drilling depth in 1 millimeter. And then, after checking the sinus floor penetration, hydraulic lifting was done to detach and elevate the sinus membrane. And then, implant placement was done. So, as you can see, in this full arch implant rehabilitation cases, surgical template should be fixated with 3 anchor pins to minimize tilting of template. So if we can perform crestal approach sinus lifting through the guide hole, we can minimize the risk of sinus membrane population. Also, we can regenerate the bone inside the sinus cavity through this procedure. Right, same as the left side, right side, crestal approach sinus lifting was done with one casket and hydro lifting and implant placement was done. Right after implant placement, I opened the flap from the anterior side to perform the GBR. Because of very severe periodontitis, labial bone was gone. Also, to make ideal labial bone support around the implant, contouring augmentation was done and gap management was done. So, primary closure was done. Only for the immediate implant placement side, flap elevation was done. Posterior area, I didn't open the flap. In the lower jaw, I placed 6 implants. And then I connected prefabricated customized abutment to lower 3 implants. And then with the prefabricated provisional restoration, I performed immediate loading. So this is CBCT after implant placement. As you guys can see, sinus membrane was elevated very well without any sinus membrane perforation. Under the elevated sinus membrane, there was a stabilization of blood clot. I didn't pack the bone. Here, should we always pack the bone inside the sinus cavity to get the new bone formation? I don't think so. According to the residual bone height, we can skip the bone grafting procedure only if we can detach and elevate the sinus membrane well without perforation. In these cases, I didn't pack the bone. I just elevate and detach and elevate the sinus membrane. I hold the elevated sinus membrane with the implant. Under the elevated sinus membrane, there was a blood clot stabilization. You can see beautiful and successful bone regeneration. Yeah, this is a research about that. This is a research about no bone grafting, crestal approach sinus lifting. Interestingly, average gain in bone height inside the sinus was 4.7 millimeter. So, if the residual bone height is greater than 6.0 millimeter, we don't need to pack the bone, because if we can detach and elevate the sinus membrane without adding perforation, we can regenerate the bone in about 4 millimeter. So, 18 weeks after implant placement, soft tissue got healed very well. The GBL side, you can see the augmented alveolar bone volume around the anterior implant. So, when performing second stage surgery, we can utilize previously used surgical template to find out implant position. So, I placed previously used one guy surgical template again, and then planless second stage surgery was done. So, 20 weeks after implant placement, soft tissue got healed very well around the healing abutment. It's time to make fixed type prosthesis. So, 20 weeks after implant placement, fixed type progeroid restoration was fabricated and delivered to my patient. And this is a post fixed type progeroid restoration for the upper jaw. The lower jaw, this patient used prefabricated provisional restoration. And then this provisional restoration was converted to final restoration by my prosthodontist. So let's compare before and after. As you guys can see, if vertical dimension and the jaw relationship is favorable, we can do very simple full arch implant rehabilitation by utilizing digital guided implant surgery. So this is my routine protocol for full arch implant rehabilitation. This is a panorama of the final prosthesis delivery. All implants were placed in ideal position at the center of restorative crown. But let's talk about some complicated cases here. In case of double full arch implant rehabilitation or jaw relationship, pre-existing jaw relationship and vertical dimension are not unfavorable, what should we do? We should reconstruct vertical dimension and jaw relationship and occlusal plan. So double full arch implant rehabilitation is quite challenging because we cannot have any reference. The only reference we can use is a face. Patient's face is the only reference when reconstructing vertical dimension and the occlusal plan. So traditionally, for full arch implant rehabilitation, we utilize this articulator to transfer patient pre-existing maxillary position to the articulator. We utilized Facebook. But I thought a lot and wrong. How can we combine intraoral data and the CBCT data and patient face data in digital method? So when performing digital guided implant surgery, intraoral scan data and CBCT file should be combined. So if we can put one more data, patient scan data about our patient, we can see more we can consider some more things. So, in this day, I'm using this face scanner to get three-dimensional information of patient face, not mouth. So, like this, intraoral scanning, and then CBCT. For the conventional digital guided implant surgery, these two data enough. But in case of double full arch implant rehabilitation or pre-existing vertical dimension and the occlusal plan and jaw relationship are not favorable. At that case, we can use face scanner to get three-dimensional information of face. So also, if we can combine these three different data together, we can make virtual patient. That will be a dental avatar. With this dental avatar, we can see many things. By using patient's face, we can decide ideal occlusal plan, we can decide ideal vertical dimension. We can decide ideal position of upper anterior teeth. Our lab technician can decide appropriate length of upper anterior teeth. As you know, upper central incisor is quite important. So, let's see this case. Let's talk about this treatment concept in detail with case presentation. The first case, this patient was 50 years old male patient, reported to my clinic to have fixed type prosthesis. As you can see, this patient didn't use denture. This patient didn't have any posterior occlusal stop. So this is a pre-op condition. Also, the periodontal condition of remaining teeth was poor. So this is a treatment flow of this patient. I placed implant with digital guided implant surgery. In the lower jaw, I performed immediate loading with fixed type provisional restoration, but I didn't prepare the provisional restoration. Right after implant placement, I took an impression and my lab technician could make and fabricate fixed type provisional restoration within 1 week. In the upper jaw, as you can see, crestal upper sinus lifting and massive GBR was done. So in the upper jaw, complete denture was planned as a provisional restoration. So pre-op condition, lateral view and the occlusal view. But what is the main problem of this patient? Because this patient didn't have any posterior occlusal stop. My prosthodontist could not find out ideal CR position. As you can see, there was very severe COCR discrepancy because of unstable bite. This is a habitual bite position, and this is ideal CR position. But because this patient didn't have any posterior occlusal stop, mandible guidance was quite challenging. So traditionally, to treat this kind of patient, we should remove entire teeth, and then we should make temporary denture to guide mandible to CR position. Because the only reliable position for full arch implant rehabilitation is a CR. So, but how can it decrease that period? How can it accommodate my patient to newly established mandibular position? By utilizing digital technology, we can expect the amount of mandible movement. So I took a CBCT, large F-voice CBCT, to find out condyle position. And then I took a face scan. And also I took a intraoral scanning. These three data are combined together to make dental avatar. So during evaluation, we could realize that condyle was displaced anteriorly. Because, as I mentioned before, this patient didn't have any posterior occlusal stop. Entire mandible was displaced anteriorly. So, you can see the condyle position here. Anteriorly displaced condyle position from both sides. So, but how can he move this mandible to the ideal side in the CR position? 2 millimeter? 3 millimeter? And how can he check, how can he expect the direction of mandibular movement about and backward? Uncertainty. So, to minimize this uncertainty, I utilized this CAD program. By using the CAD program, only mandible part from the CBCT, only mandible part can be extracted and can be repositioned. STL file of mandible can be extracted, and then this mandible, extracted mandible part can be repositioned. Also here, this is a preop condition, maxilla. Here, after condyle repositioning, after moving mandible in ideal condyle position at the center of the condyle fossa, based on that reposition mandibular position, diagnostic workup was done. Here. Also, when making diagnostic workup, we can refer to interpupillary line and campus line to decide ideal occlusal plan. So this is a virtuality. Even though we can make very good treatment planning with CAD program, how can we make this virtuality to reality? This is just virtuality. How can we make this virtuality to reality? This is the final result of this patient. So, to make virtuality to the reality, implant position is most important. So, based on this prosthetic design, based on this diagnostic workup, implant planning was done. So, as I mentioned before, in the upper jaw, we plan complete denture as a provisional restoration. So, based on this diagnostic workup, my leg technician could design denture in digital method. So, this is a diagnostic workup part, like tooth library and denture frenzy, and 3D printing. And coloring was done. In the lower jaw, after that, in the lower jaw, I placed implant. I usually prepare 2 surgical templates. The first surgical template was tooth and mucosa supported template for posterior implant placement. After placing several implants from the posterior area, remaining teeth were extracted, and second surgical template was placed and utilized. In the lower jaw, same as upper jaw, I placed the implant. And then, as I mentioned before, in the lower jaw, I didn't prepare any provisional restoration because the implant position and angulation was not accurate. Same as my planning, because I didn't place implant through the guide. Just final drilling was done and implant placement was done without guide to perform delicate depth control. To check the position and angulation of the implant, I opened the flap a little bit. So, pre-fabrication of provisional restoration was impossible. So, right after implant placement like this, I took an impression. But when taking pixel level impression, I usually utilize this kind of scannable healing abutment, not transfer or figure impression. Here. So, because this patient had a plan to use denture in the upper jaw, only 4 implants were selected for immediate loading with high initial stability. And then I connected Osstem's scannable healing abutment. So this is denture. In the lower jaw, I also prepared the denture, but I didn't plan to use denture, lower denture, for this patient. I prepared lower denture only for taking impression with scannable healing abutment. So with prefabricated lower complete denture, I could take an impression like this. After connecting scannable healing abutment, grind off the inner surface of lower denture, and then I took an impression, closed mouth impression. The main purpose of this impression technique is to transfer jaw relationship and the vertical dimension to the lab at the same time. So here, after making model, actually this scannable healing abutment is developed for intraoral scanner, but in this procedure, I take an impression of this scannable healing abutment, and then I made a model. Instead of intraoral scanning, the model scanning was done, and then merging was done. With this, to this scannable healing abutment, implant library could be merged and planning. Even though I took an impression, entire lab workflow was same as modelist workflow. So next visit, this is customized abutment and one-piece type PMMA bridge was fabricated and delivered. So these four implants were temporary implants. To protect my permanent implant, I placed 4 more implants. And upper jaw, 3D printed denture was delivered. In that way, I could accommodate my patient to this newly developed, newly established mandibular position. So with this, I took a CBCT. Sorry. You guys can see repositioned condyle, right side and the left side. Let's compare before and after. Immediate before surgery and after post-provisional restoration delivery. Right condyle, this is a before surgery and after provisional restoration delivery. So second surgery was done in the maxilla. Right after removing the cover screw, I connected scannable healing abutment. In the previous case, I connected conventional healing abutment, but in this case, I connected scannable healing abutment. And then, same as lower side, impression taking was done with the copy denture and scannable healing abutment. With this impression technique, I could take a bite and jaw relationship and vertical dimension at the same time. And so, in the upper jaw, fixed type provisional restoration was fabricated and delivered, and the lower jaw, second, fixed type provisional restoration was fabricated and delivered to final implant. This is final restoration. Let's see the condyle position here, left condyle and right condyle. You can see the ideally positioned condyle before and after. And this is the right condyle. After delivering post-provisional restoration, after final restoration, you can see the ideal condyle positioning of left side here and here. So second case, in this case, this patient reported to my clinic to place implant in the mandible. So chief complaint was a gum boil around abutment teeth of limbar partial denture. So can you guys check any problem of this patient with the panorama? So here. So same as my protocol. I took a CBCT and intraoral scanning and face scan. So after making dental avatar, I could realize that mandible was deviated in right side. So left condyle was displaced anteriorly. The previous case was entire mandible displacement in anterior direction, but in this case, rotation case. Left condyle was displaced anteriorly, so entire mandible was deviated in right side. So here, this is a center of the nose, this is a chin. So as I check in the CBCT, the entire mandible was deviated in right side. So same as previous case, mandibular repositioning was done in the CAD program, and then this is free op. This is a before, and this is after mandibular condyle repositioning. After repositioning of the condyle, we could secure sufficient vertical dimension for crown. With this status, vertical space for final prosthesis was insufficient. So after repositioning the mandible in ideal position, we could realize that vertical dimension could be increased. So diagnostic waxer was done after condyle repositioning. Here. So this is a diagnostic waxer in the dental avatar. So same as previous case, to transfer this planned implant position to my patient mouth exactly, I utilized digital guided implant surgery. Drilling and implant placement was done, and GBR was done. And also I placed 4 more implants as a temporary implant in the mandible. So I connected scannable healing abutment like this, and then I took an impression. And then bite registration was done like this. So with this scannable healing abutment and the confidential technique, we can take an impression and vertical dimension and jaw relationship at the same time. So we can decrease the number of patient visits, we can decrease the entire treatment period. So model scaling was done, and based on this vertical dimension, fixed type provisional restoration could be designed and fabricated and delivered. One except implant placement, fixed type provisional restoration could be fabricated and connected to the implant. In the upper jaw, full mouth rehabilitation was done after some implant placement from the left side to make a new occlusal plan. Pre-existing prosthesis was removed from the maxilla, and extraction was done from left maxilla, and implant placement was done. Here, let's see. After delivering fixed type provisional restoration in the mandible, you can see ideal repositioning of left condyle. Here and here. So upper jaw, the lower jaw, second provisional restoration was fabricated and delivered to permanent implant. We don't need to remove temporary implant, just submerge after connecting the cover screw. So for the permanent implant, second provisional restoration was fabricated and delivered. So this is the final result. 4 months after implant placement, final prosthesis could be fabricated and delivered. And you can see the newly established occlusal plan and vertical dimension. And also, we should check the condyle position again here. Right condyle and left condyle. Both condyle were repositioned in ideal position, so without any mandible deviation. So this is a comparison before and after. Yeah, this is a patient movement. Patient could be accommodated to this newly developed mandible position. In that point of view, fixed type provisional restoration is quite attractive. With removable type provisional restoration, patient accommodation will be challenging. By delivering lower fixed type provisional restoration right after surgery, my patient could be accommodated to newly developed mandibular position very well. So there was no TMJ problem. This is a 1-year follow-up. gingival condition around implant prosthesis was quite good. There was no TMJ problem. So finally, vertical dimension of the dental site is greater than 1.5 millimeter. And also, deep support is sufficient. At that situation, we can consider fixed old implant rehabilitation called Oronex. So the main purpose of posterior implant tilting is to increase the space between implants. In order to maximize AP spread between implants, posterior implant should be placed with a tilting angle. In this way, we can avoid anatomical structure, sinus flow, sinus, and mental foramen. So as we all know, cantilever length should not exceed twice the AP spread of implant, or maximum 20 millimeter. So by maximizing inter-implant distance, AP spread of the implant, we can maximize the cantilever length. Also, we can minimize mechanical problem. But just like this case, when considering Oronex treatment, how can we control the tilting angle of the posterior implant? By utilizing this dental avatar concept, we can control the tilting angle of posterior implant, 17 degree or 30 degree. Also, just like this case, in this case, I place 4 implants: intraoral scanning, CBCT, and face scan. And I could make dental avatar. With this dental avatar, I could check the vertical dimension and occlusal plan. Pre-existing occlusal plan was not so good. So with this diagnostic workshop, I recommended new upper denture fabrication for my patient because occlusal plan was so poor. Anyway, I planned 4 implants. 2 anterior implants should be placed parallel to each other. 2 posterior implants should be placed appropriate tilting angle. Guide was placed and fixated with anchor pin and drilling. Intermediate drilling was done, and then after removing template, final drilling was done and implant placement was done. As I mentioned before, anterior 2 implants was placed parallel to each other. Posterior implant was placed with appropriate and accurate tilting angle, same as my planning. So in that way, we can prepare appropriate multi-unit abutment and multi-angle abutment. There are 2 different degrees of multi-angle abutment, 17 and 30. So for the anterior implant, to change the connection, one-piece type multi-unit abutment was connected, and posterior implant to compensate tilting angle of posterior implant, multi-angle abutment. You guys can see parallelism by connecting multi-unit and multi-angle abutment. And over this multi-unit and the multi-angle abutment, temporary cylinder were connected. And then prefabricated PMMA bridge was connected to this temporary cylinder at the same day, right after surgery. So quite attractive point of Oronex treatment concept is a tooth in a day. This patient can have fixed type provisional restoration at the same day of surgery. So after successful osseo integration, upper denture was fabricated again. New denture was fabricated for maxilla and delivered, and the lower jaw fixed type final restoration was fabricated and connected to the implant. So I want to conclude my presentation with this. Previously, implant was placed where it could be placed, bone-driven implant placement. In 1965, Dr. Brennemark has placed implant to the human for the first time. At that time, bone-driven implant placement concept. Implant was placed where there could be placed. But in this day, restoration-driven implant placement concept is popular. So implant should be placed where there should be. But For the full arch implant rehabilitation cases, I think facial-driven implant placement should be emphasized. In case of double full arch or pre-existing vertical dimension and the jaw relationship is unfavorable, at that time, this face-driven implant placement concept is quite helpful. Please do not miss the forest for the trees. Focus on the forest. Do not focus on trees. In that point of view, digital will be a game changer. I think digital make us fly to infinity and beyond. Thank you so much.
Dr. Kim, thank you for this great, wonderful presentation. We're going to have questions, but before audition, I have a question, if you don't mind.
Yeah.
I was wondering, do you always utilize Facebook while doing full arch rehabilitations, or is there any way not to use it?
So actually, I'm oral surgeon. So prosthetic procedure was done by my prosthodontist. But you asked about the Facebook.
Yes. Do you always utilize Facebook while doing full arch rehabilitations?
Usually, as oral and maxillofacial surgeon, I usually use the Facebook for the orthodontic surgery. But the full arch implant rehabilitation cases, I didn't use any Facebook. But my prosthodontist usually use the Facebook and the articulate mounting for the full arch cases. Yeah.
Okay, thank you. Thank you for the answer. Arkadaşlar, soru cevap kısmına geçiyoruz. Sorularımız varsa kısımlar, onlara arkadaşlarımız mikrofon getirecektir. Şurada bir soru var, ön tarafta.
Good morning, I'm Dr. Ahmet İbrahimoğlu. Thank you for an amazing presentation. You know, we are in Turkey.
Duyuyoruz, problem yok.
It is nowadays in Turkey very popular is health tourism. And a lot of patients came to us and they are making full arch rehabilitation of upper and lower jaw. And they want to finish their tooth immediately for one day. And in your cases in full arch rehabilitation, I saw that you use customized abutment. And we know that it takes time. So my question is this: why don't you use a multi-unit abutment, or is it another thing which we don't know? Maybe customized abutment is working better in this case. Because we know when we use multi-unit abutment, we can make immediate loading in the same time. Thank you.
Yeah. So even though you can use the multi-unit abutment, you should connect the temporary cylinder and you should prepare some temporary bridge or crown shell, right? So in my clinic, I have my own lab. So I could make a customized abutment within 3 hours after scanning or impression taking. But as I presented, for the oral next treatment, for the oral next, oral 4, oral 6, at that time I usually use a multi-unit abutment. But if you guys can place implant parallel to each other, in that situation, we don't need to use a multi-angle abutment. No need to compensate the tilting angle of the implant. As I presented, if we can place the implant parallel to each other with the digital guided implant surgery, we can use stock abutment, or you can use customized abutment.
Evet, başka sorusu olan? Bir soru daha var arka tarafta.
Geçici diş yaparken vakalarınızda geçici diş yaparken PMMA kullanıyorsunuz sürekli. İçinden herhangi bir kırılmayı engelleyecek bir tel ya da bir metal bir parça olmuyor gördüğüm kadarıyla. Hatta son 4 implantlı vakanızda 2'şer de kanat atılmıştı PMMA'ya. Yani bunun ortadan kırılma durumunda implantların bağlantısı, bütünlüğü bozulacak ve implant kayıpları yaşamayacak mısınız böyle bir durumda? Yani kırık problemi yaşamıyor musunuz?
Yeah, very good question. So, when according to the opposite arch status, we can consider some reinforcing of provisional restoration. But most of full arch implant cases, especially for the immediate loading cases, immediate loading usually performed in the lower jaw. In the upper jaw, patient was using complete denture. So we don't need to worry about some fracture of PMMA, provisional restoration. Also, if we can splint several implants together, if we can perform cross-arch stabilization, the risk of implant failure, the risk of provisional restoration fracture can be minimized. But when patient opposite tooth status is a natural tooth or implant prosthesis, at that time, we can consider metal reinforcing, wire reinforcing inside the PMMA bridging.
Teşekkür ederiz. Başka sorusu var. Bir arkadaşımız daha var.
Öncelikle sunumunuz için teşekkürler. Ben de bu all-on for ya da custom abutment vakalarıyla alakalı soracağım. Şimdi ilk vakanızda yine custom abutment kullandınız. Sonraki vakalarda evet multi unitler de var. Şimdi hep bu implant dünyasında tartışılır. İşte vidalı mı yapalım, simante mi yapalım? Yani ikisini de yapabildiğimiz durumlarda siz mesela bu custom abutment'lar kullandığınızda simantasyonu nasıl sağlıyorsunuz ve mesela vidalı restorasyonlar için en önemli şey servis verilebilir, sürdürülebilir. Yani hekim dostu ve hasta dostu uygulamalardır denilir. Mesela bu tarz simante yaptığınız vakalarda işte ve blok çalıştığınızda üst yapıda bir sorun olduğunda bunu nasıl çözüyorsunuz? Tekrar çıkarmak, takmak, yeniden yapmak gibi durumlarda ne şekilde hareket ediyorsunuz? Teşekkürler.
Yeah. So, could you turn on this slide? Please change it, convert the slide. Yeah. Like this. So I usually make a hole. So SCRP type, hybrid type, cement screw and cement retained prosthesis. So this is a customized abutment. After connecting the customized abutment to the implant, we can cement this prosthesis with the permanent cement. And then we can remove we can remove this abutment along with the crown, and we can remove the cement excess. And also, through this screw access hole, remnant of cement, excess cement will be drained out easily. So in that way, I could minimize the risk of cement remnant.
Evet, bir sorumuz daha var.
Aynı şekilde çalışıyoruz ama ilk vakanızda sanırım sadece simante kullandınız ve delikli değildi kron. O tarz vakalar için sormuştum ben. Yani vidayı açamadığınız, vidanın vestibülden ya da lingualden çıktığı, sadece simante çalışmak zorunda kaldığınız vakalar. Yani ikisini de yapabildiğimiz durumlarda sizce hangisini seçmeliyiz?
Yeah. So in the anterior implant placement cases, when the screw access hole will be formed through the labial side of final prosthesis, at that time, my prosthesis prefer cement retained type. But for that situation, my prosthesis always use temporary cement, polycarboxylate cement. And also, my prosthesis always prepare the 3D printing cementation model. The abutment part will be printed out, and then when cementing the final prosthesis to the abutment, cement application and over this cementation model with 3D printed cementation model and placing and remove the cement excess and place again to minimize the amount of cement remnant.
Son bir soru alacağız. Hocam buyurun.
Öncelikle teşekkür ediyorum sorunuz için. Bu kondilin anterior repozisyon olduğu durumlarda full ark tedavilerinde kondili tekrar yerine konumlandırdığınız vakalarda öncesinde hastaya bir süre protez kullandırıp implant cerrahisine öyle mi geçiyorsunuz yoksa direkt kondili implant cerrahisiyle tekrar yerine mi konumlandırıyorsunuz?
So, by utilizing this dental avatar concept, the position, the mandible position can be reliable. So, after repositioning the mandible in ideal position, and prosthetic design will be done, and based on the prosthetic design, implant placement planning will be done. So, to transfer the planned implant position to the patient's mouth exactly, digital guided implant surgery will be done. And then, fixed type provisional restoration. When making provisional restoration, right after implant placement, for the as a post provisional restoration, that diagnostic workshop should be reported. That is my protocol. So, as you ask, I usually place implant right after extraction, but that planning should be done after ideal mandible repositioning and condyle repositioning.
Arkadaşlar sorular için teşekkür ederiz. Doktor Kim'i muhteşem sunumu için bir kez daha alkışlayalım. Günün ikinci konuşmasına geçiyoruz. Yine Güney Kore'den Doktor Kim Chingu. Doktor Kim Chingu, Yonsei Üniversitesi Diş Hekimliği Fakültesi'nde başlayan akademik yolculuğuna yüksek lisans ve doktora dereceleriyle devam etti. Maryland Üniversitesi Diş Hekimliği Fakültesi'nde yardımcı profesör ve dekan yardımcılığı görevlerinde bulundu. Ayrıca Osstem Implant'ın Antalya'da kurs direktörü ve akademik işler direktörü olarak önemli roller üstlendi. Kim Chingu hem eğitimde hem de akademik yönetimde gösterdiği liderlik ile diş hekimliği alanında önemli iz bırakan hekimlerden biri. Ve bugünün sunumu dar kretlerde basitleştirilmiş guide cerrahisi teknikleri. Kim Chingu için bir alkış istiyorum sizden arkadaşlar.
Good morning. This is another Kim. As you know, in Korea, there are so many Kims. Today, my lecture is about the GBL. Actually, as you know, with the guided surgery, we can save our time or save the mobility for the patient to perform GBL because we can place implant in the right position. Okay, so today I will suggest the decision criteria for ridge augmentation techniques with the guided surgery. As you know, guided surgery provides so many various advantages for us. First, the primary advantage is to place implant right position where we want it to place. As you see, with guide surgery, we can place implant with accuracy. There are very minimal displacement of implant could be found after implant surgery with guide surgery. But as you see, with the present surgery, even though the implant was placed by a prosthodontist or a surgeon, it could be not optimal position than the guided surgery. So, like this. This publication provide that how guide surgery could be helpful for reduce the incidence of surgical intervention, rigid augmentation. With the surgical intervention score, guide surgery was proven that let us do less surgical intervention for rigid augmentation. So like this, we can reduce the incidence of rigid augmentation. And as you know, basically guided surgery is designed for flange surgery. In many articles, flange surgery shows less bone loss and better soft tissue architecture preservation than flap surgery. I agree with this point of view. But there are some disadvantages. With flange surgery, we cannot observe underlying bone during the surgery. So sometimes we can miss the interbony bone defect, and implant could be placed in poor location sometimes. As you know, with guide surgery, sometimes jewelry will be displaced during drilling, and implant position will be changed where we expect it to place. So sometimes we cannot use a flange guide surgery in immediate case or pre-existing bone defect case. And place the implant after extraction, placing implant only cannot reduce or cannot agitate the bone loss after extraction. So we need additional rigid augmentation with immediate implant placement case. Because unfortunately, after tooth extraction, especially buccal and labial plate will be lost by time. As Otto proved this in his article, in the first phase, vertical eruption, and second phase, outer surface of buccal bundle bone will be disappeared. And Dr. Chopis told that thin bone, less than 1 mm, will be reserved more than the thick bone, and soft tissue thickening masks this, so we cannot find where is bone or not. Unfortunately, the thickness of facial bone in anterior maxilla is very thin. As you see, it is about 1 mm or less than 1 inch. For decades, so many studies were done to find what is the critical factor to determine the result of immediate GBL. So, contemporary theories are focusing on labial wall thickness. As you see, only thick labial bone thickness and socket graft or immediate implant placement with GBL can reduce the gingival recession. It means that this procedure can reduce the ridge risks and height reduction change. And we have to think about his gap distance. As you know, more gap distance leads more bone loss, unfortunately. But if we can make the enough gap distance from the implant surface to the outer surface of the bone, we can fill more bone graft material to the vocally. It can be the good situation for us to augment the ridge condition. Like this, more gap distance with more labial bone resorption. But it is a two-way sword, I think. And for this reason, sometimes we have to consider open flap surgery, and sometimes we have to consider flap surgery. But in aspect of bone filling, flap surgery shows better result. Why? we can see the gap exactly and we can fill exactly with accuracy. So, open flap surgery gives us some advantages. Despite of them, as you know, flap surgery gave us so many things. The first thing is to reduce the swelling and post-op pain and hemorrhage and with high accuracy. So we have to choose flap or flap surgery for the guide surgery. Okay, so now I am suggesting the decision criteria for rehabilitation with guide surgery. This is my decision tree. For practicable rehabilitation for guide surgery, I think these 3 points. The first thing is labial thickness, and the second point is implant to vocal bone gap, and lastly is soft tissue condition. Okay, I will explain these 3 for next, but in the situation of thin labial vocal bone and the gap is not enough, and final soft tissue condition, I try to open flap conventional tubular surgery. But the labial plate is not in thickness and the gap is not enough for implant the situation that I have to place implant in vocally or first tissue condition or multiple implant placement case, I choose a mild tibia with the collagenate ball or thick labial plate and enough gap to fill the gap. In this case, I like to use usual wrap with collagenate bone wrap material. This is the first point, labial thickness. A chop is tall, thin bone is reserved more, and thick bone or the 1 mm is less, like this. In this patient, in the pre-op CT, vocal plate was 2.5 millimeters, and I placed implant with the one guide surgery, and there's minimal bone graft. And after 2 years, there's no change of vocal bone thickness. How about this case? 0.5 millimeter labial bone thickness was remained. After extraction, as you see, I augmented a lot despite of this huge augmentation. After 6 months, only 1.5 mils were remained here. This is the second point to choose the modalities for rehabilitation. It is IBP, implant to vocal bone plate distance. It means that external implant collar to bony surface of vocal plate. It was trained by Capelli. In case of IBP was less than 4 millimeters, and in this case, and we perform only internal grafting, bone will be lost. And in this case, we need external bone grafting. How about this case? As you see, we can see enough space to fill the bone to the outer surface of the implant and the bony wall on the labial plate. In the case, we can finish the case with only inter-socket bone grafting. How about this case? Despite of thick labial thickness, implant to bony wall distance is not enough. It's less than 4 millimeters. In the case, we need intra and inter-socket graft. Boozer and Granda told that our goal for rehabilitation, especially in anterior, is to make the labial thickness as 2 millimeters. This 2 millimeters means that after healing. For this, we have augmented more in the surgery. I think more than 4 to 5 millimeters is required to make the 2 millimeter bone thickness at the bone cavity. And last condition is soft tissue condition. As you know, soft tissue condition affects so much to our surgery. Sometimes poor wound state, soft tissue condition affect our surgery, and sometimes they causes wound adhesions or infection or huge inflammation, the kind of problems. So we have to think about this. Thick and clean soft tissue condition is good point for open flap surgery sometimes. Like this, fine soft tissue condition with fine soft tissue healing, even though if we had performed the advanced surgery. And like this, gingival recession or inflammation with wound dehiscence sometimes, and poor instrumentation result will be followed. And despite the poor soft tissue condition, in case of flap surgery or minor flap elevation surgery, shows normally fine lesion. Okay, let's see one by one. The first option is conventional GBL techniques. Let's see this patient, young male patient, and he wanted to get the implant treatment on his anterior mandible. And as you see, after orthodontic treatment, 4 anterior teeth was pulping. In the CT, there are not enough bone, and the labial bone plate is not enough. So I decided to perform ongar surgery and conventional open flap GBL. As you see, the labial plate is thin and implant bone flap distance is not enough. So in this case, I choose the open flap GBL. So after extraction, I place implants here with one guide, like this. 2 implants was placed, both lateral incisors, and GBL was performed, like this, with gel graft, and first membrane was applied, and pyramidal abutment was applied too, and bone tech fixation was done on apical area. And I delivered processes for visual processes like this at 2 weeks, 4 months. And finally, I delivered final processes. And as you see, after 4 years, aesthetic result was acceptable to me. And in the CT scan, you can see the comparison of pre-op and post-op CT. More than 4 years, augmented buccal bone volume was very stable, and we can see the totalization of the labial plate. As you see, we can manage this case well with the open flap surgery, with the guide surgery. Let's see. Next case. Another young male patient. And he wanted to get the implant treatment on the left central incisor maxilla. As you see, there's a root resorption. So I planned this implant with the one-guide system. And let's see. As you see, it's very hard to find the labial plate. Loss of labial plate is observed, and buccal dehiscence defect was found too. So I decided to open flap GBL. As you see, soft tissue condition was quite good. Right after extraction, I checked the buccal fenestration defect, and I placed implant with one guide template, and I filled the socket intrasocket and socket with the general graft like this. Enough bone grafting was done, and I covered them with the plastic membrane. As you see, primitive abutment was applied here, and apex, I fixed the apex of the membrane with the bone tack. The provisional crown was delivered at the 2 weeks, 6 weeks. After 3 months, I delivered my processes like this. At 6 months, 2 years. Soft tissue condition and little comfort was preserved well. Like this. But we can find something. In CDCT, after post-op, in the post-op CT, I augmented about 5 to 6 millimeters in width. Despite of them, after 2 years, only 1 or 2 millimeters is left on the buccal side. So, what I want to tell you is that we have to augment enough. Sometimes 4 to 5 millimeters of bone augmentation will be not enough. Anyway, this patient, the first was surgery satisfactory. Patient was feel good and it was stable for 3 years. Okay, let's see next case. This is a similar patient. Let's see the CT of this patient. As you see, there's a bone loss on the lingual plate. There's no bone structure on the palatal side. So I decided to place implant with longer system and the CT goes to lingual plate, and the high scientific factor will be made after surgery, and IVP is not enough. So I decided to open flap GBI for this patient. After extraction, and I opened the body flap for this patient, and decortication for the buccal plate was done. And I placed implant with the longer system. I performed extra or GBI with the general graft was done, and suture was done too. And temporary PMMA temporary abutment was applied here, and healing was 5. Finally, I delivered my final processes. And after 1 year, soft tissue condition is fine. Of course, very small recession was found on the genesis of the crown, but I think it's acceptable thing. The CT scan, despite the huge amount of bone augmentation, after 1 year, the buccal plate is not enough, but I think it's acceptable. It's about 2 mils, and I think it's enough. Okay, then, without this conventional GBI technique, we can take other techniques. It is simplified GBI techniques. The first thing is duodenum graft. Actually, duodenum graft was presented by Stephen Chu and this Turner over 10 years ago. They told that they divided this area 2 zones, tissue zone and bone zone. Actually, we tried to fill the graft material only bone zone, but they claim that we have to augment to the tissue too. It means that they suggest that do not open the flap, and a traumatic extraction of tooth must be done. After that, bone grafting must be done on the bone zone and tissue zone, and security and the provisional crown must be applied right after GBL for the sealing of soft tissue. So this is duodenum graft concept. It consists of 2 points: bone grafting on the soft tissue zone and sealing with the temporary crown. They suggest that for this duodenum graft, we can save 1 millimeter of vertical recession. Okay, let's see the case. this is my first case for dual graft. As you see, there's a little fracture here, so I decided to place implant with it here, one guy system. And as you see, in the planning, label plate loss was found and vocal diaxin defect was found. But we can secure enough IVP in this case. So I decided to dual graft. After extraction, I performed a traumatic extraction and I placed implant here with one guy system like this, and implant was placed on the palata plate, and I performed bone grafting, dual grafting with the bios collagen. This collagen type of mobile bone is now widely used, and as you see, this graft material must be filled to the top of the soft tissue margin. And we deliver temporary processes. And as you see, we can find there are convex. We have to make this convex vocal profile. And of course, this temporary crown must be deducted like this. Anyway, deliver temporary crown here, and 1 year, and 3, 5 years. So something this recession is not found like this. But in the CT, despite of dual graft, vocal plate thickness is not enough. Despite of this flow result in the X-ray, the real situation, patient feels no aesthetic problem, and there's no other mechanical or biological problem. So I think he put it fine. Okay, let's see another case. His patient was 63 years of male, and there are advanced peritonitis, so I tried to place implant here with one guy system. Let's see the CT. How about this? This patient has very thick labial plates here. And how about the vocal gap? I think it's enough. And soft tissue condition was very good. So in this case, I decided to perform dual graft. So right after extraction, I placed implant with the one guy system. After that, I fill the vocal gap with the AS collagen. And also, I fill the tonic side with the AS collagen too. Why? Because this tonic side is related with the final aesthetics. If we did not fill this area will be lost symbolically, and finally we can see the poor aesthetics, especially in this anterior maxilla. Anyway, I filled this gap all with the collagenated bone, and I delivered temporary crown like this. After 2 weeks, 2 months, soft tissue healed well, and after 3 months, I delivered final prosthesis. As you see, vocal volume was preserved well, and after 3 months, and after 3 years, soft tissue texture preserved well, and there was no soft tissue recession and aesthetic problem. In the CT scan, for 2 years, vocal plate was preserved well. Why? As I told you, vocal thickness was high enough. Okay, let's see one more case. Young female patient and anterior maxilla. After extraction, before the extraction, I took the CT, and in the CT, after their vocal plate loss was found, and but we can secure the enough IVP. In case of we can place implant on the palatal, and such condition was fine too. So I decided to deodorant grafts. After extraction, as you see, no flap elevation and no incision was done here. And after debridement, I placed implant with one guide template, and as you see, implant was placed totally. And I fill the buccal gap with the collagen, the graft material, the bovine bone, and temporary crown was applied here, like this. After 1 month, patients wanted to get the gingivectomy by gummy smart, so I performed it too. And after 3 months, I delivered my processes. And soft texture was preserved well. And after 5 months, after 2 years, as you see, acidic problem and complication was not found here. In the CT scan, I did not open the flap and I just filled the local gap with the progenitor bone. Despite of them, buccal plate was preserved well. About 2 mm is left after 2 years. I think it's enough. Okay. And this is the next representation modality. Simplified geometric 2 is minor trivia. How can I perform this? Let's see the case. I can explain with the case. 7 years old female patient. She wanted to get the anti-implant. It's in Korea and she was living in United States. She visited Korea to get the implant treatment. So the CT scan, how about this? Buccal bone is, I think, fit and intact, but gap is not enough to place. So in this case, I decided to buy the studio. Like this. Right after extraction, after extraction of 4 anterior teeth, I decided to place 3 implants here. 2 implants and 3 crowns. I placed 2 implants with 1 guide system, and for this patient, I performed minor GBR with the AUS collagen. Nowadays, we call it as the L-shaped technique claimed by moderatörlüğünde. Anyway, this kind of surgery was done for this patient, and right after surgery, temporary crown was delivered. So after 2 weeks, the soft condition is not good. Despite of them, the second healing was acquired like this. And after 3 months, I delivered final processes for this patient. As you see, we were fine. And in the CT, I performed GBL without any kind of membrane, wide flap open, only pressure incision and very small flap elevation, and I feel the progenitor bone on the buccal side. And I think it is not satisfactory, but I think it's acceptable. So you can see this case very simple. Let's see another case. 48 years old male patient, and he wanted to get the multiple implant treatment on the mandible. But as you know, during the multiple implant surgery, this augmentation with large flap open and large flap operation is, I think, it is very complicated and it's hard to perform. So, in the CT scan, labrum plate is thick and intact, and after surgery, implant could be placed to the middle of the lid in the case, vocal gap could be not enough. So, in this case, I decided to perform minor GBR with the collagenate ball. So, after implant placement with one guide system, multiple implant system, and I connect the abutment first. After that, I fill the vocal gap and vocal augmentation over the outer surface of the vocal plate with the collagenate ball. Layer collagen was applied here, and suture was done. There was no collagen membrane coverage. Anyway, provisional crown was delivered and 5 implants was placed here. After 4 months, final processes was delivered like this. After 2 years, despite the poor well hygiene, this aesthetic result was acceptable. So, what I want to tell you with this simplified GBR technique is that we can perform lateral rotation a little bit easier than the open flap surgery, but the result is acceptable in aspect of aesthetics. And in the city, after 2 years, vocal plate is, I think, is enough. And there's a new polycarbonate lining was found here, so I think this bone will be stable for more years. Anterior tube. Okay, let's see one more case. Middle-aged female patient, heavy smoker. I extracted the anterior tooth already prior to place implant, and I wait. After flap elevation, despite the lateral augmentation right after extraction, which condition is not enough, place implant well. So in this case, I place implant with one guide system, and I augmented more with collagen native bone on the vocal side to augment vocal volume. And without membrane coverage, I did the suture and processes were delivered like this. The 3 months final crown was delivered like this. And as you see, vocal plate after 3 years, we can see there's a not enough but acceptable thickness, maybe 2 millimeters was left like this. So I think we can manage this complicated case very easy with the collagenate bone augmentation, this simplified GBR technique. Okay. So this is my dysentery for lateral augmentation for guided surgery. Especially, I focus for anterior maxilla or anterior mandible. As you know, in the posterior region, any kind of GBL could be fine, and you don't need to perform immediate implant surgery or guide surgery for the posterior region. So, in case of thin vocal plate and small gap and a fine soft tissue condition, my suggestion is open flap GBL, or vocal plate is enough, and larger gap could be made by lingual position of implant and soft tissue condition is good or not. In the case, we can choose the dual implant, the easy way to preserve soft tissue high for a long time. And multiple implant case, a poor soft tissue condition, and small gap, and thick labial plate. In the case, my suggestion is minor GBL with collagenate. This is my information. This is a tree for guided surgery. And we have to think about the position. For this, implant must be placed to the lingually to secure enough space to fill the bone on the buccal side. And suture primary closure is required for good result at the regional patient. And for open flap surgery, we have to consider this. Remained bone after open flap GBL is rely on space creation. As you see, I augmented about 6 millimeters on the corner part of the buccal side, and after 4 months, only 2 or 3 millimeters left, and after 2 years, they go well. So, my recommendation is to fix the membrane well on the apex of the GBI side to secure the space. And the main bone after usual rod after healing is rely on original bone thickness. In this case, as you see, this patient has very thick bone thickness on the buccal side, and to addition that, I augmented more in the socket defect. And after surgery, after 3 months, as you see, about 7 millimeter bone thickness left on the labial side, and after 3 years, there's no bone resorption here. And normally, bone loss pronounced more at apical area than corner part. So, for sometimes, this implant apex area shows very thin bone thickness at the healing or 2 or 3 years later. But this area is not related with the aesthetics. So I think we have to think about this. This article is about the duodenal graft. 10 years later, the duodenal graft was claimed and presented. Dr. Yongjin shows this article that duodenal graft group shows significantly better result in horizontal bone reduction and soft tissue height. Our concern is always soft tissue height and its reduction, and many articles probe this. For simplified GBR techniques, remained bone after these simplified GBR techniques is relied on original bone thickness too, like duodenal graft. So, to change the fate of labial bone thickness, we have to perform wide open flap surgery, the conventional surgery. With only conventional surgery, we can change the fate of thin labial bone plate. We have to think about this. In this article, Sanj Martin uses 3 techniques. At left, bioguide membrane was applied only, and right side, bias collagen was applied without membrane. And the center, bias collagen and bioguide membrane coverage was done. In this area, as a result, bias collagen plus bioguide group shows similar result with the bias collagen only. I think it can explain that without the L-shaped technique without collagen membrane coverage. And some authors claim and presented this totally technique. Without flap elevation, we can make the stab incision on the apical area, and we can use the bone grafting through this small incision. We call it as a tunneling technique. Many authors claim that is very effective. So now I want to show my case. about 10 years ago, I placed implant with one guy set here. Like this, one guy was placed here and implant process was delivered. But for this case, to reduce the soft tissue recession, I decided to perform this tunneling technique. So I made vertical incision of the apex of the implant placement, and I performed the tunneling technique with the bios collagen like this. And it looked fine. But in the CT, as you see, I augmented a lot with the bios collagen like this. Despite of them, after 5 years, there's no bony structure with the vocal side. So, what I want to tell you with this case is that coloring technique is not reliable for now. And this article of Bennett shows that collagen to wrist after literal augmentation shows better in black type bone graft material, just like the bios collagen or EOS collagen like collagenated bone shows better result after literal augmentation for a long time. But there's another problem. This collagenated bone shows less new bone ratio. It could be sometimes problematic to place implant where the augmented leads with this collagenated bone. So my recommendation is that using this collagenated bone for literal augmentation must be done with the simultaneous replacement. It could be fine. And we always think about the heart tissue, but heart tissue is not all that determines the success. Like this, only about 60% of patients with GBR did not show perfect soft tissue complexity. It means that sometimes we need soft tissue augmentations. In this article, Schneider told that the change of entire literal condition was decided by GBR in 60% and 40% was changed by soft tissue augmentation. So sometimes we have considered this CTG or FCG background for literal augmentation and soft tissue augmentation. So this is conclusion. Flatness or minor surgery is a fine modality for guided surgery to maximize aesthetics and to reduce the soft tissue recession. But word thickness is a key parameter to decide the rehabilitation techniques. And to secure enough vocable space is a key for long-term success. Thank you.
Evet, Doktor Bu'ya bu güzel sunum için teşekkür ediyoruz. Sorusu olan arkadaşlarımız var mı?
Teşekkürler. Yani size 2 tane sorum neydi? Gösterdiğiniz vakalarda gördüğümüz görüntülerde ağızda implant varken, empatmentlar varken grefleme yaptınız ve devam ettiniz. Şöyle bir teknikten bahsedilir. Yani eğer bir şekilde sert doku greflemesi yapıyorsanız hemen kapatmak zorundasınız. Enfeksiyon kontrolü sağlayabilirsiniz diye. Böyle vakalarınızda enfeksiyon kontrolü nasıl sağlıyorsunuz? Özel bir şey yapıyor musunuz? Ya da yani hem ağızda batmantılar varken grefleme yaptığınız, sert doku greflemesi yaptığınızda bir enfeksiyonla karşılaştığınızda bunu nasıl yönetiyorsunuz? İlk sorum buydu. İkinci sorumda bunlarda gösterdiğiniz bir tünel tünel tekniğinde işte 5. yılın sonunda burada kemik kalmadığından bahsettiniz. Acaba burada 5. yılın sonundaki rezorpsiyon tünel tekniğinin kendisinden mi kaynaklanıyor? Yoksa kullanılan malzemenin rezorpsiyon etkisinden anlatan. Yani başka bir malzeme kullanırsak, otojen graft kullanırsak benim benzer yaklaşık bir 10 yıldır takip ettiğim vaka var. Aynı şekilde tünel tekniği yaptım. Son
Geçen sene de bunun bir kontrol açısını aldım. Yani yerinde duruyor kemik ama buradaki 5. yıl sonundaki kemik kaybı acaba materyalin kendinden mi kaynaklı? Otojen ya da sığır kaynaklı bir kemik kullansak da bu şekilde rezorpsiyonla karşılaşır mıyız?
Okay. You gave me two questions. The first question is that how to prevent the infection of the right? Yeah. Actually, as I told you, sometimes we can encounter some complications just like infection or severe swelling, and they're caused by inflammation of basal glands. So for this, we have to remove all the glands and tissue inside the socket. Well, it is the first option, and we can use some antibiotics locally and systemically. I like to use the damaged socket at the damaged socket with the antibiotics, just like the tetracycline, rinse and soaking before placement. Right after extraction, after removing the dirty things inside from the socket, and I soaked the socket with the tetracycline solution for 1 minute. After that, you can reduce the infection. And we have to also give the patient the prescription for the antibiotics for systemic. And the second question is that about the failure of the tunnel technique. You asked me that the poor leisure was caused by the bone graft material, and I have it, right? But I think the general graft, the bovine bone and progenitor bone, actually they can survive well. But the problem is not, I think the problem is not related with the graft material. I think we cannot perform decortication for the lateral plate sometimes, and where by the tendon after bone grafting, this tendon can be harmful for augmenting enough space for bone filling. Actually, will be augmenting. So I think this is a very complicated problem. But in many articles, like many authors claim that this kind of current technique could be fine. But I think in my experience, current technique shows, in my experience, poor leisure for a long time. So there could be some controversies.
Sorulan var mı? Soru daha olabilir. So, Doktor Bey, thank you for this beautiful lecture. Arkadaşlar bir kez daha alkışlayalım. Doktor Buyur.